morning and thank you very much. And so I was talking this on behalf of Dr. Praveen Chandra. So I would just show some cases with where we used support devices. This is one of the patients of protected PCI. This was a 77-year-old male, a diabetic and hypertensive, with history of pulmonary tuberculosis in a few years ago, and history of cerebrovascular accident some years ago, and with history of partial nephrectomy for renal cell carcinoma, and he also had prostate cancer for which he had orchidectomy. So he had triple vessel disease, and he had come with he had unstable angina, and so he came with ACS, but he was hospitalized for bypass surgery. But after some time, the surgeons declined, and since he was referred to us, as surgeons declined, his ejection fraction was only 40%. So he had diffuse calcific disease. If you could see, there is a lot of the entire LAD. I'm sorry. So there is a total OM. There is a proximal LAD lesion. You can see the distal LAD is heavily calcified. There is not much of flow, and the right coronary artery is quite diffusely diseased from proximal to mid segment. And with severe LV dysfunction, the elderly man with multiple comorbid, so we thought we should, because surgeons declined, and we had decided to go with protected PCI. So we decided to go for an Impella support. So this is an Impella CP. So our Impella program is relatively new. We started about a year back, and so you can see that the Impella is in place. You can see the pulmonary pressure is very high to start with, but stabilized here. You can see the pulmonary pressure. We always do hemodynamic monitoring, and with the Impella, we can see the output is 3 liters per minute, which is quite good augmentation. And the placement, if you could see the motor current is 841. So with that, we decided to proceed with the PCI. So we started with the LAD, and so it's a heavily calcified lesion, so straight away we went for, we couldn't pass a wire, so we had to small balloon dilatation and then pass it and take the exchange to a rota wire, and then we started with a 1.5 millimeter burr. So then we upsized to 2 millimeter burr. The proximal LAD lesion didn't give way. So then you could see that there was a waste again in the mid LAD with the balloon. You could see this after the rotablation. You could see that there is significant waste in the balloon, and that's when we decided to use an IVL as well. So this was a 3 into 12 millimeter IVL, which we used 4 cycles. We thought we'll keep the remaining with 4 cycles. I think the balloon, and you can see this is after the IVL. We kept the remaining IVL for the right, and followed by that we stented it, and I think we put 2 stents, 2 long stents, and we had to use a guide liner. If you could see that the strings couldn't go. So we had to use guide liner, guide extension to track the stents, and this was the proximal LAD stent, and this was the final result. You could see that we did IVS. So then move to the right coronary artery. Again, you could see that right coronary artery required, there's a lot of calcium right from the ostium. So we straight away exchanged to a rota wire and started, I could see the guiding catheter backing out. So we had to be extremely careful when we start, when we ablate the osteal lesions. And this is following the rotablation. again we put a NC balloon, and you could see that the waste, we know that rotablation acts more on the superficial calcium, and as similar to LED, you had a lot of waste in the balloon, suggesting that we need more calcium modification before we stent. So we try to use the same the IVL which we used for LED, but for some reasons the balloon was a bit damaged and we couldn't use it. So we decided to cut down the cost. We tried to use OPN balloon, which in fact didn't really help. You could see that this OPN balloon, 2.5 10 millimeter OPN balloon, still having a lot of waste. So finally we didn't have no option, so we had again taken an IVL, and this was the IVL at 8 cycles. And we could achieve some amount of calcium modification. And you could see the waste is after IVL, we used a NC balloon, and now the waste is almost disappeared. And then we stented it. So you could see the stent going very well after good modification. And again, we put 2 stents, a long stent, the mid LED, and proximal RCA stent. And this was the final result for the right coronary artery. So we could achieve near complete revascularization with protected PCI using multiple calcium modification devices. Again, let me show you another case, then we can have a discussion. This is a 54-year-old man who was a known diabetic and hypertensive. He had recent onset of symptoms with the breathlessness, with paroxysmal nocturnal dyspnea. His echo showed moderate LV dysfunction, ejection fraction of 40%. So this was the angiogram. I'm sorry for the poor quality because this angiogram was done in another institute. You could see that there is a lot of diffuse disease in the mid-distal LAD. There is a critical ostial left main lesion, and also the right coronary was diseased, more diffusely diseased and distally. So this, all the OMs are occluded. So basically a triple vessel disease with the left main bifurcation lesion with diffuse disease in the distal LAD. So again, after I think the surgeons turned down again because of the too much of distal disease, no good targets, and considering that this patient has a multiple triple vessel disease with left main with LV dysfunction, we use protected PCI with Impella, and this is the PA pressures 32 by 19. So we used the Impella 2.5 in this case, and you could see you can see the augmentation is 2.4 liters per minute, and the motor current appears good. The placement appears to be good. So this is the pressures. After we put in the Impella, the PA pressures came down. You could see the 16 by 9, and so we started with the OM. So we started with the OM, and this is of stenting of the OM, which was not too difficult. And then we moved to LAD, and we started working on the distal LAD, pre-dilatation, stenting. This was kind of more of a very soft lesion. Considering that he's a young patient, we didn't have to use much of aggressive preparation, lesion preparation. And this was a drug-coated balloon. Too distally, we used a drug-coated balloon. There's a magic touch, a sirolimus-eluting drug-coated balloon. And after that, we stented the mid-LAD and the mid-LAD. And then we moved to the left main. So we stented from the left main to the LAD. And then we decided to do a tap to the circumflex. So this was all Zion stent. And this was a kissing balloon after we stented from left main to LAD, and this is a tap with the stent in the circumflex. And this was a kissing balloon after we stented after the tap, stenting both the LAD and the circumflex. And Sorry, media is not playing. Okay, then we did a IVS. Okay, so I'm sorry, the IVS run is not playing, but you could see that there was some amount of under expansion of the mid LED stent, so which we were able to correct it and post LED the mid and the distal LED stent, mid and the proximal LED stent. Also, we made sure we achieved a good area at the ostium of the LED and the left main, and you could see here in the proximal LED we were able to achieve an area of 10 square millimeters, and also in the left main we were able to achieve 19 square millimeters, and this is at the distal left main and the ostial left main. We were able to achieve adequate areas. So we got away. Both patients did well, and we got away with protected PCI. So it's very challenging to treat these kind of multiple lesions with diffuse disease. So we used a drug-coated balloon for distal lesions. So protected PCI in these challenging subsets, I think we have to use optimal devices to prepare the lesion as well as to use imaging guidance to get the best optimal results. Thank you.